This presentation will review the basic principles of thoracic ultrasound, including exam indications and exam technique. Then we'll illustrate some of the normal thoracic ultrasound findings, including A-lines. Finally, we will discuss some of the pathological findings that can be appreciated on thoracic ultrasound, including pleural effusion, pneumonia, and pulmonary edema. The goal of point-of-care ultrasound is to answer a focused question. Using thoracic point-of-care ultrasound in clinical practice can help answer, why is my patient short of breath? It may also give insight into the etiology of a patient's chest pain. There are several benefits to using ultrasound for assessing the lungs. First, ultrasound is easily reproducible and can be used to track response to therapy and following thoracentesis. There's no radiation emitted by ultrasound, unlike CAT scan and X-ray. Bedside ultrasound provides an answer in a matter of minutes and does not require moving the patient away from critical care treatment areas. Most point-of-care ultrasound are portable and easy to maneuver between patient rooms. And transthoracic ultrasound is non-invasive and generally tolerated well by patients. Now let's discuss some of the evidence supporting point-of-care thoracic ultrasound. Ultrasound is more sensitive than supine radiograph in detecting pneumothorax. This has been described in a series of blunt trauma patients in the emergency department by Blavis, Soldati, and Zhang in 3 separate studies using CAT scan as a criterion standard. Ultrasound to evaluate for pneumothorax has been found to be helpful outside the emergency department as well. 47 pneumothoraces were found by ultrasound that had been previously missed by chest X-ray in a group of 200 non-traumatic ICU patients. A pneumothorax will settle in the anterior chest in a supine patient, rendering it difficult to view on a supine chest X-ray. Pneumothorax is further discussed in the EFAS lecture in this series. Thoracic ultrasound has higher sensitivity and higher diagnostic accuracy than auscultation and supine X-ray in detecting pleural effusions, pneumonia, and pulmonary edema in intubated patients. There are 2 studies that explore this. The first study looked at 32 intubated patients that were in acute respiratory distress syndrome with ultrasound compared to supine chest X-ray and auscultation. A similar study examined 42 intubated ICU patients and compared ultrasound with supine chest X-ray. Both studies found that ultrasound had better sensitivity, specificity, and diagnostic accuracy than supine X-ray for pleural effusion, pneumonia, and pulmonary edema. The criterion standard was chest CT for both studies. A study of climbers showed increased B lines, which are markers of pulmonary edema, at the time of clinical diagnosis of high-altitude pulmonary edema, and also resultant decreased number of B lines at the time of clinical resolution of high-altitude pulmonary edema. Because of its portability, ultrasound may be easier to access than X-ray in remote areas and could provide useful information in austere environments. Now we'll discuss the technique for performing thoracic ultrasound. Critical care pulmonary ultrasound was pioneered by European intensivists Lichtenstein and Mizeri. To perform thoracic ultrasound, the chest is divided into virtual scanning zones. There is variability in how many zones of the chest are examined in study protocols throughout the literature, ranging from 4 to 12, and is dependent on what pathology you seek. This picture illustrates 4 scanning zones on the right side of the chest. This is part of an 8-zone scanning protocol adapted from Volpicelli's 2006 American Journal of Emergency Medicine article, and is used to investigate all lung lobes for pneumonia and edema. The remaining 4 zones, numbered 4 through 8, are on the left side of the chest and are mirror images of zones 1 through 4. In examining a patient for CHF, a recent article suggests that a 2-zone protocol looking only at zones 1 and 5 demonstrated similar results to this full 8-zone protocol for ruling in CHF. This abbreviated 4-view protocol can be helpful for looking for pneumothorax and pleural effusion and briefly examining for pulmonary edema. The 4 views include the second intercostal spaces in the mid-clavicular lines and the intercostal spaces in the mid-axillary line near the 8th to 10th rib spaces on the right and the 6th to 8th rib spaces on the left. Despite the chest's tight rib spaces, a low-frequency probe is ideal for thoracic ultrasound due to its available depth of penetration. However, a high-frequency probe can be helpful in visualizing subtle pneumothorax and pleural pathology due to its increased resolution. When placing the probe on the patient's chest, the probe indicator should be oriented towards the patient's head with the probe in a longitudinal plane perpendicular to the chest wall. By exploring the anterior superior chest first, you will be able to note the presence or absence of lung sliding, thus quickly in or ruling out a pneumothorax, arguably the most critical of lung pathologies seen on ultrasound. By performing thoracic ultrasound on both sides of the chest, you will be able to compare any pathological findings to the patient's normal lung, or, in the setting of having two abnormal lungs, you will be able to appreciate the extent of the pathological processes. Finally, the patient's position can affect identification of lung pathology. Of course, patient's comfort should be first priority. However, water is heavier than air, and therefore it will settle in the dependent portions of the thorax. Upright positioning can help characterize a pleural effusion and guide thoracentesis. Otherwise, traditionally lung ultrasound is performed with the patient in the supine position. This picture illustrates the appropriate probe position for scanning the anterior chest, or Zone 1. Zone 1 and 5 are best for looking at lung sliding and artifacts associated with pulmonary edema. Here is an ultrasound image of a lung in the anterior chest. Take a few seconds to orient yourself to the image on the screen. The probe is on top of the chest, with the indicator pointing towards the head, so the side of the image by the blue dot is relatively superior to the rest of the image, while the right side of the image is closer to the feet. The top of the screen correlates with the most anterior or superficial structures, while the bottom of the screen demonstrates the posterior structures. This is normal lung sliding, with the arrow pointing to the pleural line. These horizontal lines coming down from the pleural line are A-lines, which we'll discuss in a few slides. Here you can see an intercostal space with rib shadows. The upper and lower rib shadows, with the bright pleural line in the middle, appears like a bat, and you may hear this view referred to as the batwing view. This is the appropriate probe positioning for scanning the right lateral chest, or Zone 4. The probe indicator is pointing cephalad. Zones 4 and 8 are best for viewing pleural effusions. Note that this examiner in the picture is using a phased array probe. Either the phased array or curvilinear probe will work, with the curvilinear probe being slightly better given its increased depth of penetration. Here is an image of a lung in the lateral chest. Take a few seconds to orient yourself to the image on the screen. The probe is pointing cephalad. The probe is on the side of the lower chest. Those structures on the left side of the image are relatively more superior, while structures on the right side of the image are closer to the feet. The structures at the top of the image correlate with what's most superficial and most lateral, while the structures at the bottom of the image are relatively more medial, deep into the body. Note the diaphragm as the bright echogenic line underneath the liver. Here is an ultrasound still of the right lateral chest, with the diaphragm appearing as an echogenic bright white line separating the liver from the lung. This is the same orientation on the left side of the chest. Let's take a few minutes to discuss mirror artifact. It looks like the lung tissue in this image has the appearance of the liver or the spleen. This is from a phenomenon known as mirror artifact, when it seems that there are similar structures on either side of a highly reflective interface. In this case, the diaphragm acts as a mirror and reflects the ultrasound beam back into the liver. The sound wave bounces to the transducer via the diaphragm. The ultrasound machine incorrectly times the redirected ultrasound beam and creates an image anomaly on the screen. This results in intrahepatic structures appearing as if cephalad to the diaphragm. This usually occurs when there's an object in front of a highly reflective surface, such as the diaphragm. Here is a diagram further explaining mirror artifact. The green top triangle is a real object. A normal sound wave hits it and echoes back to the ultrasound system appropriately, thus demonstrating the true form of the object on the ultrasound machine. This ultrasound beam is not shown in this diagram for clarity's sake. The blue arrow is an ultrasound beam that hits the diaphragm. It reflects off the diaphragm and is denoted by the orange arrow, which hits the area of the true triangle and then reflects back to the diaphragm as demonstrated by the black arrow. That beam is ultimately reflected back to the ultrasound machine as the red arrow. The ultrasound machine mistimes the beam, and the mirror image of the object that was reflected appears below the reflected surface. Now let's discuss pathology seen on thoracic ultrasound, including pleural effusion, pulmonary edema, and pneumonia. This picture illustrates the appropriate probe positioning for scanning the right lateral chest, or Zone 4 for an effusion. Zone 8 is the same location on the left. In looking for a pleural effusion, look for a dark anechoic fluid collection above the diaphragm. If fluid is seen, move the probe cephalad to ascertain the extent of the pleural effusion. Sensitivity for viewing pleural effusions improves by having the patient upright. A case report in the radiology literature from 1982 mentions an effusion that was missed on chest x-ray when a patient was supine, but then was detected when the patient was moved to an upright position. In a 2006 article, Tayal recommends upright patient positioning to quickly detect pleural effusion with ultrasound. A left pleural effusion is present in this clip. It is the anechoic area to the left of the spleen and the diaphragm. Pleural effusions are noted along the diaphragm. Remember, water is heavier than air, and so will settle in the dependent portion of the thoracic cavity. In a recent series of intubated patients in the ICU published in the critical care literature, ultrasound was found to be 100% sensitive and specific for detecting effusion. Supine chest x-ray was only 65% sensitive and 81% specific. Chest CT was the criterion standard. In the setting of a pleural effusion, the lung can become compressed by fluid and takes on the appearance of liver. This is called hepatization. Let's spend a few minutes to discuss reverberation artifact. Understanding reverberation artifact is important for the other two pathologies we will discuss in this lecture. Reverberation artifact occurs when two or more strong acoustic reflectors are encountered in the path of an ultrasound beam. In some situations, the probe can serve as one of the reflectors. The ultrasound beam repeatedly reflects back and forth between the two structures, causing multiple bands of equally spaced echoes that sequentially take longer to return to the transducer. This causes the ultrasound machine to mistakenly illustrate the delayed echoes as multiple equidistant spaced bands with progressively decreasing intensity at increased distance from the transducer. This is a normal view of the anterior chest. A-lines are horizontal artifacts parallel to the pleural line that indicate a normal lung surface, but are also sometimes present in states of hypervariation such as COPD and asthma. Note that the artifacts are equally spaced apart. B-lines are the linear artifacts originating from the pleural line to the bottom of the screen. They often appear like searchlights with lung sliding. It is important to note that B-lines will obliterate A-lines. It can be normal, however, to see B-lines along the diaphragm. Note the Z-lines. These are small vertical lines, less bright than the pleural line and ill-defined. They do not eliminate the underlying A-lines and don't change with lung sliding. They are only a few centimeters long. B and Z lines are vertical lung artifacts. They are both referred to as comet tails. However, Z lines are physiologic, and while the presence of 3 or more B lines is considered alveolar interstitial syndrome, if B lines are present bilaterally, it's thought to be consistent with pulmonary edema. This is a still image with pulmonary edema. B lines originate from the pleural line. 2 lungs bilaterally with 3 or more B lines is 85% sensitive and 97% specific for diagnosing radiographically present and clinically diagnosed alveolar interstitial syndrome. What is alveolar interstitial syndrome? Well, it's a pattern of thickened interlobar septa and/or ground glass on imaging studies. It comprises pathology associated with alveolar or interstitial edema, including pulmonary edema, pneumonia, and ARDS. The number and intensity of B lines increases with the degree of loss of aeration. Here are two examples of alveolar interstitial syndrome. Pneumonia appears as a hypoechoic area of varying size and shape with irregular and serrated borders, together with a heterogeneous echo texture and roughly a triangular shape. In addition, pneumonia will typically have an air bronchogram, which are multiple echoes within the lesion. Occasionally a positive fluid bronchogram, which is an echo-free tubular structure without any sort of perfusion signals, may be detectable. Bedside chest radiography is often of limited value in diagnosing pneumonia. Although current guidelines still suggest chest radiograph as the first diagnostic step in suspected pneumonia, in experienced hands, thoracic ultrasound can be employed in patients with inconclusive radiographic findings. Additionally, Spiriendo recently published an article using ultrasound to monitor alveolar recruitment and the improvement of lung aeration throughout the treatment of pneumonia. This picture shows a pleural effusion with an air bronchogram. In more than 2/3 of the time, pneumonia is accompanied by a pleural effusion. This is the fourth lung zone just above the diaphragm. There are B lines present in this clip. To the right side of the image, there is a pleural effusion. Keep in mind that lung pathology does not occur in isolation, and often there will be more than one finding on ultrasound. There are some limitations to performing thoracic ultrasound. The ultrasound beam is reflected by the air in the lungs, rendering it difficult to fully assess healthy lungs. It is difficult to completely visualize the diaphragm without lung artifact unless there is an effusion to serve as a sonographic window. Pulmonary processes can best be visualized by ultrasound when they're close to the pleura and when there's no subcutaneous emphysema and pneumothorax present. Purely central processes cannot be sonographically visualized and therefore cannot be ruled out with these techniques. In review, the literature shows that bedside thoracic ultrasound has better sensitivity and diagnostic accuracy than chest X-ray for some lung pathology. The chest is divided into virtual scanning zones. The anterior chest is most helpful in detecting pneumothorax and pulmonary edema, while the lower chest is helpful in detecting pleural effusions. Understanding artifacts is key to performing thoracic ultrasounds. A and Z lines are normal artifacts, while 3 or more B lines in 2 zones is highly suggestive of pulmonary edema. And finally, pathology rarely occurs in isolation. This last clip includes a large pleural effusion with resultant hepatization of the lung and an air bronchogram to the left of this image suggestive of pneumonia. Thank you for your attention. Please review the rest of the lectures available in this series.